All right, can we go? Can we start? You want to behave so we can actually do this, Anton?
No, I usually like misbehaving.
We are not shaming people who get COVID, Anton.
Definitely not. We're just shaming Marco.
Are we ready?
Is This Going to Kill Me? A health podcast with Howard Feldman and Dr. Anton Meyberg.
It's ironic because this is about mental health and already they are driving me dilly. It is Sunday, the 19th of March, and it's going to be a long podcast. Can you stop it, both of you? It's actually unbearable. I'm Howard Feldman, and we are taking a look today at mental health. We're looking at two aspects of it. We're going to look at the physical side, in other words, the psychiatric side, medication, and we're going to look at psychology as well. Joining me, as always, is Dr. Anton Meyberg. Today, guest in studio is David Abrahamson, psychologist in private practice. Welcome, guys. Can we try and keep this together just a little bit? Because
I can't promise.
because let's try, shall we? Shall we?
Let's.
All right. Okay. So let's just try and understand the landscape. David, if I can start with you. You are seeing people obviously coming through your practice. You've been doing this. I don't want to call you old, but you've been doing it for a hell of a long time. Has there been a shift in what you are seeing in your practice?
Howard, there's no doubt that there's been an increase in, I would say, a couple of things. Depression for sure, anxiety, absolutely. And funny enough, well, not so funny, but somatizing, where people are presenting with a lot of...
I've somatized my whole life. That's not a new thing.
But it's increased.
Oh, okay.
It definitely has increased. And I'm not sure what Anton's seeing, but certainly...
I'll get him in a minute to see what he's seeing in the practice.
Sure.
But if we can just focus on what you are seeing.
Yeah. So we're seeing a lot of somatizing where people have gone to the doctor and they're complaining of headaches, tummy aches, muscle pain, having scans, and not really finding a medical reason for it. And then being referred to us because it is physical pain. People are feeling pain.
So yeah, for anybody who hasn't been a somatizer their entire life,
Yes.
What is somatizing?
Well, somatizing is when you actually experience physical pain, wherever it might be in the body. It can be anywhere, headache, tummy ache, muscle pain. It can really be anything. But you go to a medical specialist like Anton, and there's do blood tests, then there's no findings, there's no cause or for these pains. And so the conclusion is that this is psychological, emotionally linked. And inevitably it is, something that's happening for them, anxiety, stress, which causes the body, as we know, to have that fight or flight response.
Would that indicate a little bit of denial? In other words, that they, instead of saying, I'm anxious, I'm feeling stressed, being more comfortable finding a physical place for that to express it.
Absolutely. It's such an important thing you're talking about because speaking to my colleagues, people complain, about what's happening around them. This is a pain and this is this is terrible. But they don't really talk about the
impact,
the real impact, that they are scared, that they are worried about the future, that they're worried about. So you might think, okay, people are talking about things, but they're often on a very superficial level, and sometimes very like throwaway statements.
So just because I just want to set the scene, what you are seeing is an increase in people suffering from anxiety, depression, no matter what the expression of that is. Would you agree with that statement?
Completely.
What are you seeing?
So I have to agree with that. The amount of people that I'm seeing that are coming to me with, when I like to put in inverted commas, non-finite illness. In other words, that are coming to with this somatization. So the people come to, they've got a headache or they've got severe pain in their chest, and you've done all the blood tests, you've done all the relevant scans, you've done the cardiac workup, you've done the neurological workup, and everything comes back as clear. And then you delve a bit deeper into the psychological aspects of what's going on in their lives. And you're finding that a lot of these people are being then sort of forwarded to psychologists or to psychiatrists because they need further help. I think what we're seeing at the moment is, and I've always said this, there's a huge stereotype with psychiatric or psychological or mental illness. Mental illness doesn't follow a path. It's not like when you get measles, you get a breakout of spots over your body, you get a rash, you get a ulcer in the mouth. mental illness can go in many types of forms, and one of them is somatization, as you said. So it can affect your body, it can affect your neurological functioning, it can affect how you are cognitively. But the anxiety and depression that comes with it is overwhelming, and it can take over your bodily function. It can take over your day-to-day life, and can actually suppress you and put you in a terrible, dark place. And we're seeing that people are coming to us with all issues post-COVID, post being these last 3 years of being cooped up, especially elderly patients and our younger patients. And when I say our younger patients, I think we're finding a lot that with all these kids on social media that have been sort of using that as their crutch for the last 3 years, we're seeing a lot more depression. I'm sure you'll agree with that. A lot more depression, a lot more anxiety. In fact, there's a term called TikTok tics, which is a very prevalent thing in young children, especially in young girls.
What is it?
So because they were so focused on TikTok, they've learned how to follow other people on TikTok who've got certain things like Tourette's, who've got tics, who've got abnormal movement and movement disorders. And these kids have now developed TikTok tics. So they actually walk around and they have involuntary movements, they have involuntary sounds coming out of their mouths. And it's one of the new phenomena that have developed due to this social anxiety and the stress and this claustrophobia and all these things that have come out.
Unbelievable.
Have you seen any of them?
I haven't personally seen, but I've definitely read about it, and it's real. It's absolutely real. And I think Anton's point is important, because I think, when you look at psychology and the psychological experience, we often talk about complicated trauma, and we talk about, and often complicated trauma can be...
Is complicated trauma the same as a complex trauma?
No. I think a complicated trauma would be like a succession of traumas. So, if you have a trauma after a trauma, and I think it's important what Anton's saying is to keep in mind, that COVID and the pandemic wasn't so long ago. And now in South Africa in particular, we're experiencing
our own stuff,
and things which are really, really, and not to exaggerate, can be experienced as very traumatic, stuff which affects our daily lives. So I think what Anton's saying is important by bringing up COVID, because even though it seems to have passed, the pandemic.
And yet, it's a global phenomenon. So I think it's obvious, and you're absolutely right. You can't argue that we aren't experiencing our own trauma and stress around load shedding and the future and all sorts of things. But yet, if we look at the numbers around the world, for whatever reason, and I would imagine it's what you're saying, COVID, all of this type of thing, we're seeing this anyway.
Oh, I think on a macro level, the world is not in a very stable place. We might be very far away and detached from it, but there's a serious war going on. And I think for me, yes,
but it's not far away on our phones. It's right here.
Well, that's why we go back to the social media. Yeah. And this is how it affects our children and how it affects other people. So social media is causing a major impact on the availability of how children can react with other children. In other words, children used to be more outgoing. They used to go out. They used to be with their friends. Now they're happy to stay at home, play on their phones, and have group chats on the phone at home, but they don't go out and cause any
movie
interaction.
Watch parties on their phones rather than...
And there's 2 points, I think Anton as well, is especially for the younger kids, this issue of proximity. You get kids who are very young and don't understand that the United States is very far away from South Africa. And so I've seen children who, when there have been shootings at schools, when there have been shootings in a while ago in theatre, they present with anxiety around going to school.
Because it's hard to distinguish for a kid,
for
all of us in terms of anxiety. So how do you determine, if somebody comes into your practice with something, they might have something real, but you also pick up, obviously, that there's some form of anxiety or depression. How do you decide whether maybe to refer them to a psychiatrist, to give them medication for it, or to refer somebody on to a psychologist? How do you, is it gut?
So
how do you
it's
determine
clinical acumen,
that?
it's experience. You have to be in the game for a number of years to understand the psyche of a person. They always say when you walk into a doctor's room, within the first minute, I already know whether it's psychological or whether it's medical. And it's very easy to pick up because you pick up certain nuances. In the way
Would that be in my
will
file?
I've got a wheelbarrow for you, not a file, but that's patient-doctor confidentiality.
Yes,
I don't think we should discuss
let's
that.
leave it there. Yeah.
So you can pick up from the way the person acts towards you and reacts towards your questions, and the way they are sort of giving you a history where you're going with them.
Are people honest? I mean,
I'll tell you a funny story is that men are the most dishonest
I
people
was going to say,
world.
I'll bet you it's men
But
versus women.
those
I knew
men
it
that
was
bring
gonna
their
be.
wives in, they've got no hope because the
chance.
wives tell us the truth. The man says one thing and the woman goes, really?
But
really?
then, but that's important then. If you do have a partner, take them with.
Yeah.
No, not take them with.
That's a problem.
Go
No,
with.
just because then
Why?
you go home and the wife says, "See, I told you, I knew, right?" And then the guy goes, "Well, now I really need a psychiatrist."
And then I see them in couples counseling.
All
I think we
right.
work to feed each other.
This is great.
Yeah, this is exactly.
Nice, David. Nice to see you.
So you'll figure it out. But there's different things,
So,
right?
yeah,
So
I mean, I'm being a bit blasé, but the point of the
No,
matter is
yeah.
that you generally do a full workup on a patient. In other words, you do bloods, you do an examination, you do ECGs, you do lung function tests, you do
No, I'm
scans.
assuming that you're going to check
You're
that
going to make sure
everything
that's
physical.
first, because you've got to
Yes.
make sure there's no physical malady or illness before you go towards looking at person's emotional wellness. Okay? And emotional wellness, and we don't generally refer people to psychiatrists first. The route we want to go when you see someone in your rooms, you want to refer them to a psychologist, because the psychologist is the first link to getting somebody better. If I've got someone who's got a problem, I'll say, David, I need you to see this patient because they need to actually communicate and learn how to speak their problems out and see what their problems are, because you don't just put people on medication without it. That being said, there is a role for medication for certain people with certain illnesses, and certain anxieties and depressions do very well on that, but they work together with going to see a psychologist.
So in fact, I recall we had an incident, a robbery many, many years ago. One of our kids were young and they came to see David, and David said, the anxiety level is so high that I can't treat them. They need...
Was David talking about his own anxiety level?
No, David's anxiety was extremely high, but we calmed David down.
It took a while.
You were all right.
A few
in the
cups
end.
of coffee.
We established a bit of rapport. We played some games. It was fine.
He let me win. Guess who champion over here?
The point that he was making was that unless we reduced this kid's anxiety through medication, there was actually very little work that he could do with the kid.
The two work hand in hand together.
It's so important. I like to think about it as like 0 to 10, because I'm a psychologist, can't go more than 10. So let's just go 0 to 10. But if you are experiencing, and it can be anxiety, depression, if you're experiencing extreme anxiety, for example, let's call it 9, 10 out of 10. You know, if someone hasn't experienced very high anxiety, a panic attack, it's very hard to explain what that person experiences. They are overwhelmed. And it's actually counterproductive to say to that person, well, you know, you've gone to see the psychologist. Use the skills that they have told you,
Because it's too overwhelming.
It's true. And the same thing with depression. And obviously, we want to give psychology a bit of time. We want, the sessions a bit of time. But I think for me, absolutely, you can establish very quickly whether that person is too overwhelmed to actually use and be rational and use those skills. So what Anton's saying is so important is that, of course, I would believe that psychology is the first port of call, because you want to empower the person. You want to help them to understand what they're experiencing. You want to give them skills to take away. You don't want them to be on medication all their lives.
Why not? No.
I'll tell you about it. So first, I want to just say, just to add on to what you're saying, you know, when you've got an abscess in your mouth, you're going to treat it with antibiotics. But unless you go in surgically or you use dental tools to get rid of that abscess, you're not going to be able to treat it, and the two work together. Okay. Now, your question of why you're not going to be on medication for the rest of your life. Look, I think you've got to understand that medication has side effects, and all medication has side effects. And obviously the psychiatric medication has much more side effects. There's things called extrapyramidal symptoms, where you can get different movement disorders, you can get a whole lot of complex issues developing. But going back again, I think there's a big stereotype. You know, why can't you be on medication for a condition the same way you can be on asthma medication for your life?
So that's why
the
I
same
asked
way
the
you can be
question.
on diabetic medication.
I don't mean to be
for your life.
flippant. I'm serious.
So I'll tell you the reason, and I think this is where David is coming from, is that sometimes people get stuck in a rut of being on the psychiatric medication and thinking that that's all there is, and they don't need anything else. And sometimes you can come off that medication and work together with a practitioner, whether it's cognitive behavioral therapy or any other type of therapy, to work with the person in order to get them off some of that
But
medication.
to some extent, David, don't you think that there are many cases that medication allows the person to do the work, to hold the mirror up close?
Absolutely. So in theory, you want to, if the person needs medication, then it facilitates the work, and then hopefully
Yes.
brings the person to a point where,
Yes.
where they don't need the medication,
Right.
and you kind of wean them off it. But,
Right.
And I also think for me, people start to, live their label. I'm an anxious person and I'm on medication.
I hear it.
Instead of kind of getting to a point where you're saying, I've experienced anxiety, and maybe I do get anxiety, but I now have the skills to deal with it, and it's okay if I have to go back onto the medication if I'm overwhelmed. But again, people start to then rule their lives around it. I'm a depressant. I am an anxious person. So,
and then they're
which
self-labeling themselves.
absolutely, and that restricts their ability to be in the world. In so many ways. So I think for me, it's important. It's around empowering people, and if they need medication, to be empowered. And again, everyone's different. Some people do stay on medication all their lives or for lengthy periods
And there's
of
no
time.
problem with that. I don't
Absolutely.
believe there's a problem
Yeah,
with
well,
that.
that's why I wanted to.
But
Yes.
you've got to find the balance, and that's what David's saying. You've got to find the balance to say, is it working for you? Are you
it's
hiding
going to be one of
behind
the
the
most
medication?
difficult things. It's not like your cholesterol that you can take
I've
your.
got to tell you, psychiatrists are the best prescribers of medication. They understand the neuroanatomy and the way the medicine is going to sort of coincide with you, and the interactions and the consequences.
It's got to be so difficult.
It's a very difficult thing. And
Not
they're
only
so
that
good
is
at it.
because circumstances keep changing.
Yeah.
The weather keeps changing. There's what's that called?
Well, that's why I
With the
said
weather?
climate
No,
control.
not climate change. No, man. When
Yes.
people get
Yes, when it's-
SAD, what's it called?
Yes, seasonal
SAD.
affective disorder.
Thank you. What?
I
I'm
thought you
not the
weren't labeling
psychologist
people
in the room.
Surely we've got to stop labeling people.
No, but I'm saying
yeah,
Can't
it's
call
common.
someone sad.
So my point is that if you're taking cholesterol tablets, you do a blood test and you see where your cholesterol is. You need more, you need less, you need none. This is very difficult because I could be having a very bad day today, actually feel okay tomorrow, and
Look, with medication, there's also genetics involved, and it's very, very much involved in the psychiatric medications because there's lots of studies out there showing that people have different responses to different psychiatric medications.
We've spoken about that before,
Absolutely.
David. I think the DNA.
Yes.
And we mentioned it last week as well in the
And
podcast.
it's often useful. Like if one family member, Anton, if I've seen this with psychiatrists. If one family member is on a medication, a psychiatric medication, they'd often start with that medication if someone else in the family is experiencing the same thing because of that
And
genetic.
if they've shown a good response to it.
And they've shown a good response.
Right.
So
So here's the other thing is, and I am a little bit negotiable on the age, but I'm just going to say it. I think everybody over the age of 60 should be on antidepressants. Agree or disagree? David disagrees.
I
Your body
disagree as
language,
well.
you are horrified.
I can't understand why you're saying
62.
it.
Yeah,
Eh?
may I
How old are
ask-
you now? I'm just asking for a friend.
Way below. Believe me, I've got no issue. When I need to go on this stuff, I'm going on this stuff. For the rest of my life, I'd be very happy to do it. I've got no issues with
You can
medication.
change
know
to
why.
mainstay.
Right.
why 60?
Well, because I'm not anywhere near it, and I think older people get sad, and I think they all need to be on medication.
So I think you might raising a very good point. I think when an older person loses their partner, for instance, or they have a life-changing event where they've got to move out of their house and they move into a retirement village, then I think there's a big role for that, And I think,
growing old is hard.
I don't think psychology is the role there. I think that's medication there because it's a different lifestyle, life change.
I'm going to disagree with the
Excellent.
good doctor.
Yes.
And I'm going to say yes, absolutely. When I think a lot of what I see is when people retire, and I am talking about a certain type of person, they go from working, 5 or 6 days a week. Their work defines them. It's their structure. It's their meaning. And then they go from 100 to 0. And I think for me, and I'm not talking in all situations, but I think for me, people lose their meaning when they retire or when they stop working, when they stop having a structure. So I'm certainly not saying that medication can play a role, but I do think for me, psychological guidance, even coaching on some level, because we don't want to pathologize that. Getting old isn't a pathology, but really there are things that can be done to mediate that.
Sure,
that
I think you're right,
developmental stage.
but the psychiatric evolution of the medication to help these people is huge.
Sure.
You know, and I'm going to say these people, I'm saying people who've lost somebody, or people who have a life-altering change.
Oh,
you know?
yeah.
Empty nest syndrome, when their kids move out of their house, you know, you become older then.
But is that what it is? Or is it also a combination of maybe recognizing your own mortality, not feeling great physically?
Sure, you're right about that. 100%.
Living in pain, maybe.
All of the above.
All of the above. So why don't we just recommend as a standard that older people should be on medication?
Look, there used to be a joke that they either need to make a tablet with cholesterol medication, blood pressure medication, antidepressant, aspirin, and all other things in a combined tablet that's to give to a certain populace.
Yes.
But once again, I think when I started off, I said that mental illness or emotional illness doesn't follow a pattern. So each person needs to take a different route, whether that's psychological, whether it's psychiatric, or a combination of both. You can't just say, you are diabetic, you need this medication. Even diabetics have to have education. They need to know what to eat. They need to know what to avoid. You know, they need to know to exercise. So there's a balance, and you've got to find that balance with the whole sort of circumstance.
Yeah. And I'm also going to say, I think for me, yes, we're talking about getting old, maybe because that's where we're at. But I think for me, you know, there are certain, you know, for everyone is different. And, you know, certain people find it difficult in different parts of their lives. You know, I've seen kids, young people fall completely apart when they make the transition from high school into the world.
Oh, interesting.
You know,
so it's any life change that actually, and we don't want to medicate ourselves at these points
At
and
every
not have
juncture.
the resilience, not
Absolutely.
teach ourselves the resilience.
Absolutely. There's nothing wrong, as I said, I think Anton's agreeing as well. When one is not coping, when one is overwhelmed, absolutely there's a place for it. But you know, life is tough. Life is a series of challenges and transitions. And some people find certain transitions very easily and find it easy, and some people don't. And, you know, as I say,
I'm just wondering why we have to endure, why we have to suffer something
Because
that we don't
as I said,
need
there's
to.
always been a stereotype. There's always been saying that if
That's
you're
why
on
we're having these
medication,
conversations, yeah.
then there's something wrong with you. And we're trying to say there's nothing wrong with you. It's the same as having diabetes, asthma, high blood pressure.
But are we saying that?
We are saying that.
Are we
we are
saying
saying
that?
because there's a combination of things that can be done to help people with problems. You know, that you don't have to just say, well, I've got depression and I'm going to go stay in my house by myself. No, I can see somebody, I can get help. And if that doesn't help, I can get medication. And if it does help, I can use that plus medication. So there's so many options.
Yeah, but I mean, from the medical side, I think maybe to answer your question, why hasn't everyone just gone and made up?
I think it's a super
Correct me if I'm
idea.
wrong.
Is that, so you recommend that as well?
No.
I think we should change the conversation towards that. So, David, you were saying
About those referrals. But correct me if I'm wrong, there are side effects when you take medication. So I think for
and
me,
it can make you dull, and it can make you sedated, and it can make you confused.
Okay, so
libido
it's not
can go,
it's not so simple.
yeah,
It's not so
absolutely.
simple.
Not so simple.
Let's just talk about the stereotype. Do you see it more with men, resistance to medication, resistance to therapy, more men than women?
Yeah,
That's what I would expect.
From a medical point of view, men much more. Women find it much easier to say, yes, I actually do think that I will have some medication because I know it will help me and I want to feel better.
Women are
Whereas
much
men are
smarter than men.
cowboys. Yeah, 100%. Men are cowboys, and we are going to man up, and we don't have to.
But has it not changed? Have we not
Nah,
improved? Have we not
we haven't evolved. No.
Really not?
Yeah, I agree with Anton. I think maybe slightly, but again, it does. It sounds like a stereotype, a generalization, but it really does live.
Yeah.
You know, men still out there generally feel that they should be the breadwinners, should be the tough ones, should be not show vulnerability. And that's why I say, I think for me, you know, it's almost like an epidemic or a pandemic where people, especially men, talk about how difficult things are, but they talk about it in like gee, the lights went out, and there's a war in Ukraine, and oh God, financially it's so
men
difficult.
are still talking about it at a little bit of a distance.
Yeah, because people say
not here.
Yeah, we're talking about it. We're
talking about things.
Yeah, we're not saying I'm really scared. I'm really, really worried. I stay awake at night. I have heart palpitations. I worry that I can't provide for my family.
Which is a massive thing at the moment. You know, I mean, again, around the world, but South Africa specifically, there's the worry about the future. There's the daily struggle. And the responsibility that men still feel is absolutely immense.
Immense. And I'll never forget, you know, when I stood, as you say, I've been doing this for,
Wow.
since a while.
At least he looks here.
Yeah, well, I feel like I need to sleep.
Yeah.
But let me try to stay awake. But, you know, I'll never forget in the beginning when I started doing therapy that there was this, you know, kind of like a feeling you have to give your clients these amazing kind of insights and amazing kind of like reflections. But I had a client where early on taught me a really important lesson and the power of just the person talking when this person was really in crisis and hardly said anything. And I thought, oh, gee, you know, what a waste. A really terrible therapist. What a waste. And they came back the next session and said, that was so profound for me. And what it taught me was the power of just speaking. And I know it sounds like a cliche. It sounds like such a cliche, but it is so, so powerful to get it off your chest, to really get it off your chest, to talk about how vulnerable you're feeling. As I say, that day I learned that just speaking, just creating a space and allowing someone to
makes
speak
all the difference.
is unbelievable. I think we're so caught up nowadays in let's feel it. Like what, we have to feel the what is the solution? And of course, those are also important.
Because we're in many ways, we've gone from COVID, which we were in survivor mode, to living in a country and a world that we're actually doing the same. So when you spoke earlier about trauma, I think that's important because we are we've lived through trauma and we're continuing to live through trauma. What are you seeing the impact on people around you? I mean, even in the medical space, you must see a huge fallout from the trauma that you guys have dealt with through COVID.
We see a lot of what we call post-traumatic stress, and it's not the typical post-traumatic stress where you get flashbacks of events or anything like that. It's an anxiety and a depression and an irritation and a vulnerability that we're seeing with our colleagues that just can't deal with day-to-day situations.
Irritation, actually.
No, that's because I'm sitting across from you, and I think when we started laughing at the beginning, I think my colleague David was very much on the same boat.
I'm not a psychologist, but anyway, right.
Yeah. We should check your medication. Anyway, right.
Let's do that. Yeah. So, will you give me this? Anyway, can we carry on? Sorry.
Focus.
Sorry.
I think that we're seeing it in the medical field. I think people have taken a big knock, and I always used to say, we're all coping with it, but now, down the line, 3 years later, your adrenaline levels drop because you're not in that fight and flight situation anymore. So now you've got to deal with other situations, and you actually realize what an impact these type of things have made upon you, and you see it with your colleagues.
So does it come back almost like a flashback because you'll be in the same situation?
It only comes back as a flashback if you allow it to. As David was saying, if you communicate it, if you get it off your chest, then it comes back as a flashback. But if you don't speak about it, then you don't understand what you're dealing with. You don't know why you're so irritable, why you're so anxious, what's going on.
Is a medical profession, in your view, dealing with it? I mean,
just categorically no.
So
because 99% of people, 99% of medical practitioners don't believe they've got a problem because they believe they've gotten through this scot-free and they've survived. And by surviving medically, then you survive on a mental and emotional level as well.
It's quite an indictment, actually.
Yeah, and it's the truth. And I mean, the number of suicides we see in the medical profession has definitely gone up.
Wow. David, what do you say? I mean, psychologists themselves must have. You must have been dealing with people who have lost loved ones and families broken up, through this. There's a trauma in that as well.
No, there's absolutely. But I think for me, where psychologists are, kind of where it's okay for psychologists to go see other psychologists because part of our tool. In fact, actually, a few years ago, there was talk about psychologists going to be able to prescribe certain things if we did a 6 month to a year course, but. I'm so glad that it didn't happen because I think, it is our only kind of resource, our only way of helping people is to talk. And I think for me, because of that, I think it's what we use as our tool, So I think there's less of a stigma among psychologists to say, I also have to go speak to another psychologist because I feel overwhelmed. So I think for me, psychologists generally find it easier to go talk to other people. But I think I wanted to say, and it's certainly not about in a physical way, but I heard an amazing quote, actually, in a very weird place, but I thought it was very profound, where it actually says, hurt people hurt people. And I think for me, that's what I'm seeing is so much more of. People are hurt. People are vulnerable, in an emotional way. And if they don't speak about it, if they don't kind of deal with it in a productive way, they look for ways to express that hurt. And often that comes through anger and frustration.
Interesting.
So for me, if we use it in the South African context, I'm hearing about so much more road rage. I'm hearing a lot more about parents losing it with their children. I'm hearing a lot more, spouses having a lot more conflict, verbal conflict, and in some cases, physical conflict. And I think for me, this is the point. If you're hurt, you're going to hurt other people. And not because you want to. It's just that it needs to come out somewhere. Absolutely. And if you're vulnerable and you don't feel like you can speak it out in a vulnerable way, a more manly way, and we were talking about men, to show it is through aggression, to throw it through anger. And so we look.
And it actually circles back to what you were saying, how we started this, which is somatizing, finding, if you're not angry, finding a physical way. So would you agree with that?
I think that makes sense. I love that statement, that
hurt
if
people,
you're going to hurt people.
Hurt people.
And it makes perfect sense.
So what is your advice to people? We accept we've gone through hell. We are living in difficult times. What's your advice in terms of mental health?
I think my advice is that we're all in the same boat. It's not the Titanic. We're not sinking at the moment. We've got to say that there are lifeboats there to help us. We can get through this, and we've all got certain challenges we've got to deal with, and we've all got certain circumstances we're living through. But there's help. There's people you can go to get help. Speak it out, communicate, and together with communication and the psychologist and medication, or just together with building emotional bonds with people, there's a way to get through this.
Absolutely, David. And I couldn't agree more. That speaking out, allowing yourself to be really vulnerable, and maybe if it's not with a friend or with your partner, help, as Anton said,
sometimes it's easier for it to be somebody who isn't in your life every day,
and that's the advantage of being a psychologist. It's confidential.
Unfortunately, that is all we have time for. Thank you, David Abrahamson. Thank you, Anton Meyberg. Very interesting conversation as we looked to see the role of medicine and therapy, how we pull those together, looking at the choices that we can make every single day of our lives. I'd love your comments. Don't forget to subscribe below, and that way you will know when the next podcast is ready for you. I'm Howard Feldman. This is This Going to Kill Me?
Is This Going to Kill Me? A health podcast with Howard Feldman and Dr. Anton Meyberg.